Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits to save lives, save dollars, and save your talent. Okay, I wanted to switch gears. Let's talk about self-administration. Most people, if I talk to them about self-administration of claims, it's like I'm talking to them about base jumping, in the Alps. It's seen as overwhelming, intimidating, scary. A lot of people don't even want to entertain a conversation. You actually did it. Why should someone consider self-administration? And is it as scary as everybody thinks it is?
Well, I'll go back to the conversation we had about the Oakland A's.
Okay.
Lee. If you think about, the Oakland A's paid a little under $300,000 for every win they had in some of their best seasons, right?
Okay.
Because they used data to drive that. Where people like the Boston Red Sox and the Yankees were paying north of $1.7 million per win. So what the Oakland A's stumbled upon and really changed the game of baseball was how to measure the return on their capital, right? They were measuring return on how much they were investing in baseball, and what they were investing in was how to deliver wins. And they understood baseball enough that you had to get on base to win the game of baseball, and you had to do enough on defense so that you scored more runs by getting people on base than the other team did.
Right.
I think what self-administration does for you is gives you that data that you need to really be able to drive that return on the capital that you employ. So if you think about how hard that is, there's only about 4 or 5 platforms out there that adjudicate claims. They've been around most of them have been around for a long time. Some of them are a little more advanced than others. But there's a lot of people out there that are coding experts. They work for health systems. They work for carriers. So, finding people that know how to code or adjudicate claims isn't unheard of. That talent's available out there. So putting that together with the claim system, you have to be good in cybersecurity, which I think really helped us a couple of ways. Most large enterprises have a really robust cybersecurity team. They know how to build firewalls around really sensitive information. And to be honest, if you are a claim administrator and you're getting individual level detail, you've already got that kind of risk anyway, right?
Okay.
So now, if you're only getting aggregate data, it's kind of hands off. But if you're willing to and we set it up as a separate part of the organization, so it was kind of insulated, and it had its own firewall. It had its own protections. That we did our own penetration testing. We actually did our penetration testing on our partners out there too, so that we knew how secure they were. Got some issues a couple of times, but if you can do accounts payable well, it is a more advanced type of accounts payable, but it's a similar mechanism. And, you just have to make sure you got people that understand the language of healthcare. But like I said, those coding people are out there, and most of them enjoy this kind of work because they're kind of just the opposite side of what they were doing. That for our health system, they're looking for ways to add claims costs to a code. And for us as a TPA administrator, we were looking for ways to reduce cost out there.
Oh, interesting. So you wouldn't have to hire someone who strictly had come from another TPA or another carrier. You were able to hire from the other side of the house too, of anybody who worked in claims at a hospital system, and they'd come over and work on the other side. So if I've got it right, self-administration is getting a lease on some accounting software, and there's 4 or 5 that can do it, and hiring staff who know about claims coding, and presumably having some people program the software with your plan design and things like that.
Yeah, and what that does is it gives you really good control of your adjudication rate, and you could get to pick the adjudication level that is right for your organization. A lot of the TPAs are really pushing towards, some of them are upwards of 80% auto adjudication, which means the algorithm is really 90. Yeah. There's some out there. We only adjudicated maybe 5-10% of our claims. We thought it was really important for someone to take a look at them, see what was going on. We were able to spot trends a lot faster that way. So it was just you can do it. You can justify it on a cost basis when you benchmark against other solutions out there if you do it right.
How much money does it save you?
From probably at least 10-15% just on the on the adjudication, but then you get the treasure trove of data too. The certificates of coverage, certificates of benefits. Where people are going, where they're thinking about going. So it really helps drive some really better data insights as well.
Everyone, now just a quick word from today's sponsor.
The Lockbox is a place where all of our customers' healthcare benefits data is brought together into a single location that allows us to then extract insight and have repeatable value built on top of it. There's so many different pieces of information that are floating around out there that it can be hard to know what's the important elements to pay attention to and what's the underlying noise that's in the data. So what I think we do that's really critical is we help bring our expertise and our experience in modeling to help our customers understand where the real value is that enables them to make the best decision for their member population that they support. For the first time, there's a commonly understood, centrally located data model that all of your different data sources can live and that you are able to trust the quality of, to trust the security of, and ultimately to trust the insights that you're going to get out of the data that you have.
So better said, if today I'm paying my carrier $50 PEPM, are you saying it saves me 10% of that? So I'd pay $45 PEPM, or I would pay significantly less. Okay. And you were still able to rent a network as well. Okay. That's fascinating. What are the, if someone were interested in looking at this, what would be the first steps to know if it might be a good fit for them?
Well, I think you want to I always go back. So what is the problem statement you're trying to solve for?
Sure.
Right. If it's cost, then what is that delta going to be for your organization? What is the lift going to be? How many adjudicators are you going to need for the claims volume that you have? And then what is the right software platform for your organization based on the volume that you expect to see from a claims perspective?
Okay.
That will give you an idea what your labor cost and your technology cost will be. Then working with your cybersecurity team, your technology team, you understand what the parameters from the cybersecurity, the firewall protection, the penetration testing, what that's going to look like. Then you have kind of an all-in cost. And what we did is we broke it out on a per employee per month basis so that we could benchmark it.
Oh, it's interesting. Let's talk a little bit about vendor selection. Y'all were super robust in the way that you would analyze vendors and, perform selection RFPs. Let's talk a little bit about what was the process that you were using and how is it different than what most people do today?
Well, we didn't run RFPs.
What's that?
We didn't run RFPs.
You didn't run RFPs. Oh, that's a huge departure. Yeah. Okay. So no RFPs.
And the reason we didn't is because we didn't want to introduce bias into the process. And there's a lot of reasons that bias might be a part of that process, but we were really focused on what is the outcome that we expect from the solution. And really we used our analytics to figure out where our gaps were. So we knew which solutions to go after. Sometimes we found them in the market. Sometimes we didn't find them in the market. We'd have to build them ourselves.
Okay.
But when we were in a space that we knew that existed in the market, we really looked at the outcomes that they provided. Are they clinically relevant outcomes that can be verified by data? And then if that is true, then we looked at the efficiency kind of metrics that, okay, to achieve those outcomes, where is the cost associated with that? And kind of gets back to that return on capital employed kind of view of this.
Okay.
And then thirdly, then we tested it, right? If we pass that hurdle, we piloted it in our population to see if people liked it. Because if people didn't like it, and we found some that passed both of those hurdles for us that people just didn't like, right?
Wow.
So if they didn't like them, then we weren't going to get the engagement or utilization that we needed to really drive those outcomes. So it had to pass all three. And we like to get down to two and go head to head. Did that in the consulting world too. We would try to find the two best and then pilot them against each other and see which one actually performed better. Then that allows you to do some really neat things in contracting to really, instead of just an engagement number, which means 20 different things to 20 different people.
Sure.
You can base your performance guarantees around outcome achievement.
How did you keep the contracting modest so you didn't have to do two full enormous rounds of contracting with two vendors plus all the data security, implement, and then do it again if the pilot was successful? Like, that sounds unwieldy. Tell me how you got that right sized.
Well, yeah, the pilots for us were really opt-in for our population. So it was kind of a contract light. We still did security review. I mean, they had to have security if they were going to use our people, but we really didn't start passing medical data to them till we understood what the experience was like. So most of the solutions that we worked with from a pilot perspective, unless the medical claims were essential to what they were doing,
right?
We piloted them without that, which allowed us to speed up the contracting process.
It's a lot of sense.
Obviously, if you're going to exchange, you have to have the BAAs in place and everything else so that you're taking care of the information of your people.
Oh, that's wild. And so the pilot contracting, I'm guessing that if the contract was successful, it just gave you the option to continue. You didn't have to restart the process.
But what we did after, if the pilot was successful with us, then we really got into the performance guarantees. What was the right guarantee for that solution outside of just a typical engagement number. So if they were going to reduce or improve diabetic control around A1C by X%, we really ought to have goals for every one of our solutions and then hold them accountable to achieving those goals.
How much should we put at risk on those types of performance guarantees? How would you approach that?
I shot for 100% at risk most of the time. I usually didn't get that, but I think the higher at risk you could be, I think it aligns interest with the employer and the solution, so that when increase that win-win, when the client wins, the solution wins too.
I want to talk about mobile clinics. You all built mobile clinics to take around to different facilities. Very unique. Tell us the story.
Well, the value proposition we went out with was that we could speed up the hiring process for especially VOT qualified individuals out there by 50% or more, because most people had to, if in the typical hiring process, they had to go out and once they went through our hiring screening, they had to go out, make an appointment to get a DOT physical, get that back, get the results, send that to us. Typically the clinic did send that back to us. All that had to be done. And if everything worked, the person went to work, but it was kind of a drawn out process. And sometimes people wouldn't even go get their DOT physical. They'd just blow it off and you'd never see them again.
Oh no.
So when you pull a mobile clinic up to one of your facilities out there, the next step from the screening process for the HR people was to go right to the mobile clinic. So they walked right inside the mobile clinic that did their DOT physical, and they knew within days whether they were qualified and ready to go work. So, but that's really wasn't our ultimate motive of building these clinics. It worked, and we were able to justify them from a cost perspective that way.
Wow.
And they weren't as expensive as we thought they were going to be. We partnered with one of the big RV specialty makers, and we're able to give them pretty reasonably a small fraction of the cost of an on-site brick and mortar clinic. I mean, and you could take them anywhere you want to. So our real objective was to be able to attack well-being and provide high-quality primary care, which I know is near and dear to your heart too, to people in a way that it's easy for them to to uptake it. So, that's really what we were designing the mobile clinic to do, is to be able to go to our facilities. A lot of those people were working a lot of hours, and during the middle of the day, they had limited access to be able to get out to a brick and mortar facility.
Right.
So by pulling this clinic up in front of the facility, they could walk outside, take 20 or 30 minutes, and having a visit with all the, and we were able to establish what we wanted the visit to entail, right? We wanted to make sure that it was a high quality, value-based primary care visit with appropriate follow-up down the road if something was discovered. So we did lab work there. We were able to connect to virtual resources that we had in our ecosystem. So it was pretty exciting.
Wow. How many did you have?
We had one. We started out with a group called Matrix Health that was kind of didn't know what to do with their mobile clinics after COVID. So
okay.
They had a bunch of them. So we contracted with them to that was our pilot to see if this was going to work. And we contracted with them to run these kind of initiatives for us. And then we ended up building our own with Winnebago, and we'd move it around the country.
Wow. That's unbelievable. So I'm guessing if you hired a bunch of people, they'd be at a certain time and place, and you would just schedule the mobile clinic to come so you could do it in batches. Smart.
And then you hold it over a day or two and do
everybody else,
wellness visits, screenings, whatever you need to do.
Man, I love that. Now, something you mentioned earlier in the conversation about that Tom Emmerich said, we need to eliminate friction in everything that we're doing. And that gets into behavioral economics and meeting people where they're at. There's a lot that folds into that. What are other areas where we have major friction and are just missing it when you're looking around? Because you work with employers all the time. What are some of the areas where we've got a blind spot and don't realize it?
Well, one thing that Tom told me when I first met him, he said, I've got an assignment for you. He said, I want you to go to an oncology waiting room and stay there for an hour and a half.
No.
And I want you to write down what you hear. Then we're going to come back and talk about it.
No, he didn't.
He did. And, I went there, it felt pretty weird and I felt bad, a lot of really sick people there. And so I wrote down what I heard. And ironically, I didn't hear much about cancer. What I heard was the frustration with health plans. It was the red tape, the prior authorizations, the trouble scheduling MRIs, all of these scans, all of it was the bureaucracy that I heard about, and it's just sitting there. It was you'd hear some about the actual disease itself. Ironically, my brother had a really serious heart issue, so I sat in the waiting room there as well at another prominent cardiovascular health system, and I heard the same thing again. Right, so
wow.
When I got back to Tom, he said, "Well, what'd you hear?" And I said, "All this stuff around." He said, "Yes." He said, "That is the problem." He said, "We have got to figure out how to get people to the right care at the right time, at the right place, and reduce that friction so that they don't just go off and do whatever they're told. So we got to make it easier for them to do the right thing." Wow. And that's, his take on that was to, move towards COEs. And I think COEs have a space in this. But, if you go through your health plans to make sure that you're not overcomplicating what needs to happen with your population, is the first thing that we did. And,
wow.
Like really controlling what you require prior authorization on, what you don't. And why, and understand why you're requiring that prior authorization. It's like, for example, one of the really top level cancer care centers, we wait prior authorization there because we're going to trust these. We're going to watch what they're doing, but we're going to trust these people to do the right thing.
Okay. Huh. Oh, that's fascinating. Did you have any other interesting anecdotes like this of listening to people and engaging with your population? I love this story. I can only imagine if you went to a waiting room for an hour and a half. You probably did a bunch of other interesting data gathering exercises.
Yeah. Well, we started this thing, and I think you kind of alluded to it earlier in the podcast. Is we saw an uptick in comorbidities around diabetic management. So we looked at it. So obviously the usual culprit was there for us too. It was non-adherence. So we said, okay, easy enough. We'll make diabetic insulin and the supplies free if someone will just work with one of our health coaches.
Okay.
So fair enough. I thought everybody in the world was going to sign up for that, right?
Yeah, I would.
They didn't.
That seems to make sense.
We only got about 80% of our uncontrolled diabetic population sign up for this free program. So that's crazy. There's 20% of our population here that needs this stuff, that obviously are having problems, but they're not taking advantage of this program that's free. But why? So our client success team, they made calls from our TPA group, not the employer side of the house, but the TPA group that were able to make HIPAA related calls. Made calls out to these people and said, okay, you just want to make sure that you're aware of this program. And the answers that we got, I think, were gold. We had people that told us, I'm sorry, I'm not diabetic. Right. So they were in denial, even though they were clearly a diagnosed diabetic. Right.
It wasn't a false diagnosis. It was a lack of acceptance.
Yeah,
okay.
They have the history, right? They have people that told us that they just didn't have time to take insulin. They were too busy. We had people that told us that if they took insulin at work, it made them feel like they weren't as good as other people. So it was a stigma kind of thing, right?
Yeah.
So we took that information, we looked at it, and then we went back and said, okay, so what are we going to do about this? So we really employed motivational interviewing at that point. Said, okay, let's reach back out to that group. So what is important to you? So we just called up. We didn't say anything about diabetes, and said, okay, we're just here to help. And said we would like to know, what we can do to help you. And they would say, well, it's really important to me that I'm getting ready for my daughter's wedding, or I want to walk her down the aisle in 6 months. I'm trying to get ready for that, or I'm struggling with finances and I've got a sick child, whatever it was. We heard a lot of different things. So what we did is we said, okay, what can we do to help you with that? Okay. And by the way, if you really want to do some of these things in the future, it's going to be important you take care of your health. And maybe we've got a program that could help you from a diabetic management perspective too. So would you like to hear more about that? I said, yeah.
Yeah, in that context, you get a yes. You've anchored it into what's important. And calling back, you've got people thinking long term. When people are thinking about goals and things they want to change and do, they start thinking longer term about, okay, what is it that who am I going to be and what am I able to do in 10 years?
Yeah. I had a quote that I always kept on my whiteboard, and I had whiteboards all over the inside my office because I like to scribble. It's kind of like the accountant or something.
Yeah.
But it was from a Robin Williams movie, and you probably know this, Lee, but Patch Adams, when he was testifying in court, and he had this line, he said, you treat the disease, you either win or you lose. You treat the person, you win every time.
Oh, I love that.
And I think that's kind of what we've gotten in the habit of treating diseases out there, and we've forgotten that there's a person behind every one of these data points that we've got. And we got to take a really human-centric view if we're going to make significant behavioral change out there.
I love that so much. It relates a little bit, calling back to cancer as well. One of my favorite quotes ever, I was at a conference where the chief quality officer of MD Anderson was speaking, and he said, cancer now often, may not kill you, but it always takes your life. And that's almost, if you're treating the disease, you lose or you lose. And it's like, even when you win, you lose because it's so overwhelming. But if you do take a human-centric view and say, okay, something bad has happened here, but what can we do to create a better experience? How do we make it a little easier on these people? How do we help them to have resources that can lighten the burden or make it financially less catastrophic. Anyway, I love that concept.
My premise has always been, and I think regardless of whether, you're a consultant or you're an employer, that the moments that matter in an employee life cycle are really how you show up for people when they've got a problem. Okay. And I think that one of the best ways to do that is with your health and well-being plans, making sure that when you get to that point where someone's got a problem, you're there and they have you as a trusted partner in that journey. Could be a solution that you're working with, but they've all got to be aligned on how you think about handling your members. So that alignment is critically important. And that's, we did quarterly vendor summits. We did an annual. We brought everybody into Fort Smith, Arkansas every once a year.
Oh, wow.
And ran it, make sure everybody was aligned on what we were trying to do, how we were doing it, what we expected as handoffs within the ecosystem so that we could coordinate things better for our members. And that gets back to what Tom and Dee Eddington and everybody else said as well.
Everyone, now just a quick word from today's sponsor.
Mom, are you crying?
No, sweetie. Just some allergies. Come here. Let's go play. Come on.
1 in 4 Americans had trouble paying a recent medical bill. Many of these people affected work for companies just like yours. Start giving your employees 100% medical coverage with Catalyze Health.
Something that I hear a lot in the marketplace when people are trying to put in navigation firms or things like that is to say, oh, we need to have a quarterback. We need to have a quarterback in our benefits. And I've long thought that's not bad, but I think we're thinking the wrong sport, that really we don't want a quarterback. We want a basketball team where everybody passes to everybody. And you might have one person who hands it, throws it in from the side. And then once the ball is in play, everybody needs to wrap around and to drive to the optimal execution and the goal of the team, not the individual. And I think you're right on with that. Let's talk about one other thing that comes up is, how should benefits leaders build support internally? If I want to take a bold swing and I want to try something new, there might be some risk there because it's different. There might be some contract risk, or maybe it's expensive, or maybe it's disruptive. Maybe tell us a story about how you've had to get some of these programs through internally.
Well, I think, and another confession here is that I was going to be a lawyer in school.
Oh, really?
Before I switched over to business. My undergraduate in synthetical science, which may be the best thing I've ever done. I don't know. It's kind of interesting because
I love it.
That when you're trying to get something done in a big organization, it's really about coalition building.
Okay.
Right? How do you build a coalition of people that are going to help you, that see your vision? How do you help them see your vision and help you get it through the corporate structure there? So when we were trying to launch this well-being program, get wellness added is one of our core values. One of the detractors from the program was our vice president of equipment, right? And he said, we don't need to spend all this money on this. It said, it's good enough as it is. People know when they need health benefits, they got their card in their pocket. So, it said, you just need to go back and do what you're doing and leave the rest of us alone. So I called him up one day. And I was trying to think, how am I going to get through? Because I really need him on my side here. And I said, could I come over and pick up a preventive maintenance catalog for one of our trucks, right? He says, it's 84 pages and you don't understand that stuff anyway. So what are you going to do with that? And I said, I just want it. Can I get it? And he said, yeah, I'll have one printed. It'll be on my desk. Come by, you can pick it up. So I got there and I told him, I said, I've got this idea for you and I'm going to let you take credit for it. Said, let's just stop doing preventive maintenance. Said, our trucks are in great shape, right? Probably none of them are going to break tomorrow, right?
Yeah.
Yeah, and some of them may never break.
Yeah.
Right? So we couldn't do that. And he looked at me and said, I'm calling your boss. You're crazy. I said, I've always had an idea you might be. I said, but that's nuts. I said, you know what happened? You know how expensive it is to fix one of our trucks on the side of the road? I said, you know how much disruptive that's going to be for our customers? It just went on this rant. And I was just sitting there looking at him. And finally, he kind of sat back in his chair and he said, you're not talking about trucks at all, are you? Yeah, I said, no, it's the people that drive the trucks that I'm concerned about. All right. So,
wow.
After that, I think he was very valuable in helping us get that through and actively supporting it for us. So, because I've heard him tell the story. I said, if you're going to change the oil in your car, you might as well go to the doctor and do your well-being visit as well, right?
Yeah. I was like, that's getting your teeth cleaned and your vision checked, right? Every time you get an oil change.
He said, if you're not going to do your well-being visit, your wellness visit and your wellness visit, you might as well stop changing the oil in your car too.
Wow. That's great. So you made a believer out of him. I think the principle there is connecting what you're doing to business results in a way that non-healthcare wonks can understand.
That's exactly it. I reported our CFO twice a month. Mid-month, I reported, where I thought we were going to end the month and what we were doing. At the end of the month, I recorded how we actually ended the month and what we're doing. If we were good, so we're going to keep doing that. If something wasn't going right, then what we're going to do to mitigate that. So all in the language of the business.
No, I love it. Well, tell me something right now that you're working on, that you're excited about, and how can people get in touch with you?
Well, I do believe that we got to be more proactive out there. We got to attack risk more proactively. But we're building our smart workflows as part of our benefits optimization package. We're super excited about that. We've seen some pretty amazing results already, and looking forward to continuing to roll that out. It's the prescriptive piece of this. How do you help people get to the right care pathway as quickly as possible?
I love it. How can people reach you? I guess through LinkedIn if they want to reach out on other terms. Okay.
That's not too many crutches out there. I'm pretty easy to find.
Yeah, we just got to spell it right. Krut. It's perfect. Well, hey, this has been just a delight. For everybody listening, thanks for attending today. If you got as much value out of this as I did, please feel free to share it. And thanks so much for coming on the show today, Rich.
Yeah, thanks for having me. Really enjoyed it.
Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible. Until next time.